Welcome back, week 2, module 2. So this presentation is going to be a little bit longer. There's a lot of information in module 2. It's a pretty long PowerPoint, but just make sure that if you need to take a break from my annoying voice, just make sure you're doing that. Go at your own speed. Really try to take in all the information that I'm providing in this module presentation, as well as going through some of the chapters in module 2 here and gathering your own information outside of this lecture. The first thing it comes to preventing injuries is being physically fit. Okay, so if you've taken any strength and conditioning class with me over the last year, this is a concept that you should already be familiar with. The SAID principle is an acronym for the specific adaptations to impose demands. So what does that mean? This is going to mean that as we're trying to improve fitness in our athletes, we need to continually change the way in which we're training our athletes to progress them to higher levels of physical fitness. In order to create specific adaptations, we need to be very aware and constantly adapting our training programs to increase weights lifted, to change up the intensities of the exercises, change up the exercises themselves and the types of exercises that the athletes are working through, all with the goal of being able to create a sport or activity-specific adaptation that leads the athlete to becoming better and healthier. Something about me, I really like Greek mythology when I'm not learning about exercise science. Greek mythology is something that I like to nerd out about, and one story that I think is a great example of the SAID principle is the story of Milo. And Milo was a legendary Greek wrestler who wanted to become the strongest and best wrestler in all of Greece. So for his training, what he would do is every morning from the time he was very young, he adopted a calf, a bull calf, and from the time he was very young, he would carry this calf up a mountain every single day. As the calf grew into a bull, it gained weight, and as the calf gained weight, Milo had to adapt to the progressively increasing stimulus to be able to continue to carry the increasing weight of the calf. Okay, so this story is a great example of both progressive overload and the SAID principle. And just something that I thought was very relatable to what we're talking about in this slide. So the principles of conditioning. So we're going to break down each one of these. So the warm up and cool down, that's just going to give the athlete time to appropriately warm up before they engage in any activity. And we also need to consider a cool down period to help reduce muscle soreness and augment that recovery of that athlete. Motivation plays a huge part in conditioning. Athletes are generally highly self-motivated to work because they want to be successful in their sport. But that being said, no one likes to work out day after day without anything motivating them, right? And this motivation can come in forms of music that we might listen to during a workout. It can be encouraging talk from a workout partner or a friend or a coach, or even through that coach identifying areas of improvement where the athlete has already started. Overload, like we talked about in that last slide, is Milo lifting that same. If he lifted that same weight every day, if that calf never grew, he would not have continued to gain strength. He would have plateaued. His body would have become accustomed to one weight, and it wouldn't have continued to progress to an overloaded stimulus. So in order to gain physiological improvements, we need to work harder than we are used to working. Consistency, again, if Milo would not have continued to carry that bull up that mountain, if he only did it every once in a while when he felt like it, it wouldn't have been very consistent. Our athletes need to be consistent in how they're progressing through their workout programs in order to continue to reach new adaptations. So progression is where we'll go into next. That's just increasing those intensities of each workout in a gradual way. It's not getting a brand new athlete who's not used to working out and having them run 2-a-day practices immediately after they join a team. It's slowly getting that athlete to gain neural adaptations and improvements in strength and cardiovascular fitness as they move towards some sort of goal. Intensity, that's just how stressful the workout is. It's not working for long periods of time, but rather working hard in the time that you have. You can work out for an hour and have it be very low intensity, or you can work out for 10 minutes and be working at an extremely high intensity. This is something important to understand and be cautious of, because maintaining a high intensity Multiple days in a row will cause an athlete to fatigue and will inhibit their ability to recover appropriately. Specificity, specific goals for our training programs that you and your athlete have identified. Everything you do in your program should be specific to the athlete, their goals, their sport, and what they want to become. And that kind of goes into individuality, where we may have two athletes that have the same goal, but one athlete may be a varsity athlete who has been training for several years and the other one is just getting started with training. They have the same specific goal, but they have individual pathways that each must take to be able to reach those goals. And all of this has to do with safety. Understanding everything here has to do with safety. It has to be at the front of our minds when it comes to working with athletes. We need to ensure that whatever environment we're working in with an athlete it has to be safe, and that each athlete can safely work through their programs. Furthermore, we need to make sure that they can safely perform the exercises that you've listed for them. If they don't know how to do an exercise, you have to show them and ensure that they can safely perform it before allowing them to do it without any supervision. Lastly is overtraining. This is what happens when we don't pay attention to the rest of the principles. Overtraining is sometimes hard to spot because it can just look like an athlete is tired. But if you are really paying attention to your programming, you'll be able to see that an athlete has been working too hard and has not devoted enough time to and attention to resting their body and allowing it to reach the full physiological adaptations that they're training for. Muscular strength, endurance, and power. So muscular strength, this is just how much force our muscles can generate. It's how much weight an athlete can lift. So we're going to see it in a lot of different activities, from bench press to squatting. Okay, so just the maximum amount of force that our muscles can generate is what we refer to as muscular strength. Muscular endurance is being able to perform a repetitive muscular contraction against some sort of resistance or some force for an extended period of time. We're often thinking about things like cycling or running as muscular endurance, which is true, but we can also consider a plank as a muscular endurance exercise. Lastly is muscular power. This is where we're going to generate a large amount of force. Usually that force is at or near maximum amounts of muscular force. And we're going to see that generated in a very short amount of time. We see this in things like Olympic or power lifts, like the power clean or hang clean. And we're also going to see it in things like the vertical jump in basketball or volleyball, the long jump in track, or even if we're looking at a softball or baseball athlete, when they pitch or throw a ball, that also is an example of muscular power. Core stabilization training. So what is the core? I'm sure everybody here has heard somebody refer to as, oh, you got to strengthen your core. You have to work on your core. So what is the core? It's not just the abs, okay? So when we talk about the core in sports medicine, we're talking about the lumbopelvic hip complex. Okay, so it's important to include core stabilization programs in strengthening programs for many reasons. We want to improve dynamic postural control, so being able to adapt to certain situations. If we have somebody running in a straight line and an opponent hits them from the side, we want that athlete to be able to dynamically control their posture and maintain their balance in equilibrium. We want to ensure muscular balance and improve joint movements as well, allowing expressions of dynamic functional strength, being able to actually use the body the way it's meant to be used in terms of athletic performance. And then it's also going to help improve neuromuscular efficiency. It's going to be able to, through training the core, we're going to be able to move more efficiently and have less issues with our muscles cramping or moving in more jerky fashions. We're going to be able to have more fluid transition of motion through our lower and upper body. A weak core is a fundamental problem of inefficient movements, and that is going to lead to injury. So make sure that we are doing core stabilization training as a means of preventing injury in our athletes. These are some great exercises that are given through the textbook. Each of these can be made easier or harder depending on the athlete's needs, but I just want you guys to all look at them and know that they're not all just ab exercises. They're training the coordination of the lower and upper body, and they're strengthening the relationships between all the muscles of the lumbopelvic hip complex. Resistance training. So resistance training, if you were in any of my strength conditioning courses over the last year, you should know this. It should hopefully be a review for you. Even if you weren't, this should hopefully all be pretty much review. It shouldn't all be new information for you, but I'm going to kind of break down all these different forms of resistance training, all these different techniques. So starting off with isometric exercise, this is going to be when we contract a muscle without changing the length of that muscle. So if we talk about a plank, that's a great example. We are just holding our body weight in a specific position and trying to improve the strength of the musculature in that position. It's a great means of exercise for those that are injured, but it doesn't really translate to athletic performance because we are only strengthening that muscle in one specific position. Which brings us into progressive resistance exercise, which is the most commonly used technique for improving muscular strength. It's going to use exercises that strengthen muscles with either concentric or eccentric muscular actions, shortening or lengthening muscular actions, so that the length of the muscle is going to change throughout the exercise. This is seen in many, many different forms of exercise. Again, it's the most common technique with resistance training. So anytime that you see musculature moving in a plane of motion, and not staying in one specific position, we're talking about progressive resistance exercise. Isokinetic training is similar to progressive resistance exercise technique, but it's where the muscle is being lengthened or shortened at a constant rate. So we're in control of the rate at which that muscle is shortening or elongating. This is often seen in rehab settings where we're trying to gauge an athlete's true strength throughout a range of motion. In sports medicine, we use a machine called a biodex. And it's set up to move through a specific range of motion and at a constant rate of speed. So the athlete will have to be put in this machine and they will have to maximally contract throughout that entire range of motion in order to gain strength or as a means of measuring their total strength. Circuit training uses a series of exercise stations that consist of various combinations of weight training, flexibility training, body weight training, and or aerobic training exercises. And these circuits are designed to reach many different goals in a short amount of time. So that's really when we're going to see this, is if we have a workout session or a limit on the time that we can work out with an athlete, that's typically where we're going to see this circuit training show up. Typically, we're going to see anywhere from 8 to 12 stations in circuit training that the athlete is going to have to go through, and they'll have to go through anywhere from 1 time through the entire circuit to 5 times, right? The number can be larger than 1 and usually is. So typically, we're going to see them go through 8 to 12 stations 3 different times as a normal circuit training setup. There is some evidence out there to show that it's extremely beneficial for every aspect of training, but others show limited improvements specifically in aerobic capacity. So based on the research, circuit training should really be used as a technique for developing and improving muscular strength and endurance, but not necessarily cardiovascular fitness. So we're not improving our VO2 max at all. We're not improving our ability to transmit oxygen throughout our body with circuit training, but we're able to improve the ability of the muscles to use oxygen for longer periods of time with muscular endurance. Plyometric exercises, a little bit higher form of training. These are rapid eccentric stretching of a muscle, and that's going to be followed immediately by a very powerful concentric contraction of the same muscle. So this is going to include things like hopping, bounds, depth jumps for the lower body, and the upper body, we see it a lot with like med ball tosses. These, again, are great for developing muscular power, but again, they're a higher level form of exercise, so they might not be right for everyone, and they can even lead to increased risk of injury in athletes who are not as well trained. On the other side, so plyometric is for those high level athletes. On the other side of that, body weight exercises. These are pretty safe for everyone. They seem like a very low form of training, but when they're used appropriately, they can have wonderful, wonderful effects and great improvements physiologically to our athletes. I don't know if anyone here knows who David Goggins is. I've mentioned him a few times throughout some of my classes. Somebody that I use a lot as an example. He really only uses body weight training, and if you look him up, he's an absolute freak. And body weight training is his main form of training. So that just goes to show that this form of exercise, body weight exercises, they're appropriate for everyone at any skill level. And the nice thing with them is they're cheap, right? You only need your body. And almost every form of exercise, every exercise that you use, body weight training, can be adjusted based on your positioning of your body in order to gain different muscular improvements. Lastly is functional strength training. So up until now, we've really only talked about single plane, isolated muscle exercises. Functional strength training differs from the previous ones that we've talked about here because this is a technique for improving both muscular and neuromuscular control, and it occurs throughout multiple phases or planes of motion. Okay, so we're using multiple muscles and we're moving through multiple planes of motion with functional strength training. And that is going to help translate what we're doing as a workout. It's going to translate better to on-field or on-court functionality of that athlete. And these exercises are going to aim to integrate that central nervous system, and that's going to help improve proprioceptive function. And it's going to create an athlete who can reach maximal levels of strength, power, endurance in all planes of motion, as well as increasing their ability to have better body control. Cardiorespiratory fitness is important for both performance and for preventing undue fatigue that may predispose an athlete to injury. Cardio is the body's ability not just to transport oxygen throughout the body, but it's also being able to actually use that oxygen once it's reached its destination. So improvements in cardio occur because of an increase in the capability of the heart, blood vessels, blood, and the lungs in providing necessary oxygen to the working tissues. Maximum aerobic capacity is how much oxygen a person can utilize in 1 minute of maximal exercise. And we look at this because generally the greater the person's max aerobic capacity, the greater their ability is to handle higher rates of intense exercise. When it comes to cardiovascular fitness, we have to look at cardio beyond just being able to run for long periods of time. We also have to look at the ability of a person to perform work when they are intensely working and how well their body is able to utilize that oxygen that's in the body. Aerobic endurance is the ability of a person to maintain a lower level intensity of exercise for long durations of time. And then anaerobic endurance is being able to maintain activity levels during high intensity workouts that are going to demand a lot of oxygen. When it comes to body composition and weight control, we just first can refer to body composition as the fat and non-fat components of the body. Typically, in a laboratory setting, it's going to be measured in several different ways, but the gold standard is a DEXA body scan. More frequently used because it's more accessible but less reliable is the method of skin fold measurements that are measured with a caliper. There's a lot of reliability issue with that because I may find skin fold measurements on a certain person, but then you might do your measurements on the same person and find completely different measurements. So it's a valid way to measure body comp, but it's not necessarily always reliable. We have that inter-rater reliability issue with skin fold measurements with a caliper. Now, for weight control, we have to talk about caloric balance. So caloric balance is something that comes into effect when we're trying to modify a person's weight. And caloric balance is the number of calories consumed minus the number of calories expended. So calories are expended based on a person's metabolism, any work that they're performing or exercise that they're performing, and also through excretion, just through normal body processes. When we're talking specifically about gaining or losing weight, we're really talking about the same thing. We're trying to gain the greatest ratio of lean body tissue, of muscle, the ratio of body muscle, lean body tissue to fatty body tissue. Okay, the greatest ratio of muscle to fat. And generally, the best way to do either is through diet and exercise. If we're talking about losing weight, if a person wants to lose weight, they need to be in a caloric deficit. That means they need to be expending more calories than they're bringing into their body. It's important to note that we do not want an athlete to starve themselves. They should still be taking in an adequate amount of calories to support normal body function. And also, if they are exercising, we want to make sure they're still taking in calories to ensure that their muscles are building up rather than being broken down and used as energy. It's also important to note that we don't want to see any person losing more than 1.5 to 2 pounds of total body weight each week when they're on a weight loss program, because that can result in certain things that could lead to greater risk or predispose that person to injury. When it comes to gaining weight, a person needs to be in a caloric surplus. So they need to be taking in more calories than what they're expending. This sounds great. It sounds like I could eat whatever I want, but it actually can be quite difficult. I don't know if any of you are bodybuilders out there or if any of you have just tried putting on lean muscle mass, but you probably know that it's actually hard to gain weight, lean body weight. In order to see the greatest ratio of lean muscle to fat being created, that athlete is going to be gaining a maximum of only 1 to 2 pounds per week, which doesn't sound like a lot, but again, if we're talking about lean muscle tissue and not fat, we're looking at that 1 to 2 pounds per week as a pretty good rate for weight gain. Otherwise, a lot of those calories are going to be converted into fat rather than lean muscle tissue. Just a quick disclaimer, I'm going to be talking about different eating disorders here, so if you have any issues with any eating disorders in your past, or if it's triggering for you to talk about eating disorders, skip this slide and try to learn about it on your own in a way that is more comfortable for you. But some of the different forms of disordered eating here, we are going to talk about first binge eating. Not everyone has a binge eating disorder. We've all overeaten at times, right? I personally love Thanksgiving. I enjoy going to my parents' house, having turkey, stuffing, mashed potatoes, all the fixings, everything all on one plate, and then going back for seconds even when I'm extremely full and can't eat anymore. And then after I've gone for a second or third plate, I top it all off with some pie, right? So we all have binge eating episodes, but that's not a binge eating disorder. That's just enjoying food every once in a while, right? So binge eating disorders, that's where overeating becomes a recurrent problem, and a person usually does it in secret, and they typically have strong feelings of regret or shame about not being able to control their episodes of overeating. And those that have binge eating disorder, they're going to continue to eat even when they're not hungry. If they're bored, for example, they're going to go and eat, and that is going to be a recurrent problem for them where they eat until they are uncomfortable or even nauseated. To officially be classified as having a binge eating disorder, the individual, one, is going to be worried about eating a larger amount of food at one time than a normal person would consume in a 2-hour period. Again, often when they're bored or if they're depressed, that's where those episodes are going to occur. And those episodes are going to occur at least 2 times a week for a period of 6 months. And that's how we classify a binge eating disorder. Bulimia nervosa is where a person binge eats and then they feel guilty about eating and they purge what they've consumed. Those with bulimia nervosa will purge either through forced vomiting or abuse of laxatives or diuretics. They're typically going to gorge themselves with thousands of calories after a period of starvation, and then they're going to purge, and then they're going to repeat that cycle of starvation, binging, and purging. Binge purge patterns can lead to stomach rupture, they can disrupt heart rhythms, they can cause liver damage. If the person with bulimia nervosa is purging through vomiting, those stomach acids that are brought up through vomiting can erode tooth enamel and cause tooth decay. They can chronically inflame the gums of the mouth, and they can also inflame the mucus lining in the mouth and or the throat. Anorexia nervosa is characterized by a distorted body image and a major concern about gaining weight. As with bulimia, anorexia is going to affect mostly females, although it is found in men as well. This disorder typically begins in adolescence, and can be relatively mild without major consequences, or it can become life-threatening. An extremely sad statistic is that as many as 15 to 21% of those that are diagnosed with anorexia are ultimately going to die from the disorder. So it's extremely important that we recognize the signs and that we're aware of the resources available to get someone help and ultimately save their lives. In spite of an athlete appearing to everyone else as being extremely thin, the athlete with anorexia nervosa is still going to see themselves as being fat. They also deny hunger, and they're usually hyperactive. So they're going to engage in abnormal amounts of exercise, especially aerobic type exercises. And in general, it's hard to recognize because individuals with anorexia nervosa are highly secretive. So being able to recognize and then utilize early intervention strategies is essential for caring for these athletes and these patients, these people. Anorexia athletica is just a specific form of anorexia, and that is specific to athletes. It's characterized by several of the features common to anorexia nervosa, but it doesn't involve the self-starvation practices. They may exhibit a variety of signs, including the disturbance of body image. We may see a weight loss greater than 5% of their body weight. They may have GI complaints. They may have amenorrhea or absent menses, or just menstrual dysfunction. And then we also can see that they might have an extreme excessive fear of becoming obese, that they take part in those patterns of binging or purging, compulsive eating, restricting their caloric intake. And then lastly, we also might just see them losing weight, but there's no medical explanation or medical illness that explains their reduction in weight. So those are all signs of anorexia. If we recognize any of the signs associated with bulimia, anorexia, or really any of these other patterns of disordered eating, we need to address the individual in a non-judgmental, kind, and sympathetic manner. And we need to refer them to a psychological or psychiatric expert who's trained and can provide them with the help that they need. The last two that I want to talk about here, avoidant restrictive food intake disorder. Those with ARFID, they're not eating because they're in fear of gaining weight. What they are afraid of is that eating is going to have harmful consequences to their body, or they don't eat because they think that specific foods, the color, the texture, the taste, or the smell of those specific foods is harmful to them. So this goes well beyond just being a picky eater. Even though we all know picky eaters, those with ARFID are beyond being just a picky eater. They don't consume enough food. They don't have normal appetites, and oftentimes they don't grow or develop normally, because this is something that we see start with younger people. Those with ARFID are not going to grow or develop normally because they're in such a caloric deficit due to their fear of food. And then lastly is the female athlete triad syndrome. This is a potentially fatal syndrome, and it's going to involve a combination of disordered eating, and that's disordered eating other than bulimia or anorexia. And then we're also going to have that disordered eating pattern in combination with amenorrhea and osteoporosis. So in combination, these factors result in what has become known as the female athlete triad. So starting with some adverse environmental conditions, I want to talk about hyperthermia. So these are the heat illnesses that can be found in Table 7.2 in your textbooks. Hyperthermia refers to an increase in body temperature, and it is vitally important to understand when environmental heat and humidity are at dangerous levels and that we need to act accordingly. Here in Minnesota and throughout the Midwest, we typically will have extremely hot, humid summers, and that humidity is going to prevent sweat on an athlete's body from evaporating and cooling them down. So even though it may be hotter in temperature in states like Arizona, there's less humidity. So it's important that we monitor heat indexes and know when it's safe for athletes to be practicing outdoors. Only once in my career have I ever had to monitor the heat index indoors. At Princeton, our volleyball team practiced in a gym that was not air conditioned, and it was an extremely hot day, and the air in that gym was very stagnant, and it got really hot, and I had to inform the coach that the athletes would need to be treated as if they were practicing outdoors. So they needed to take frequent hydration breaks, and practice had to be limited to an hour maximum. So that just goes to show you that just because you're indoors doesn't mean that an athlete cannot be affected by hyperthermia or heat illnesses. Getting into the different types of heat illnesses here, heat stress, that's just going to occur when someone has prolonged exposure to some extreme heat, which was the case when I was working with the volleyball team at Princeton. Heat syncope. Syncope is just the word for fainting. So heat syncope or heat collapse is associated with rapid physical fatigue during overexposure to heat. It's usually caused by standing in heat for long periods of time or practicing in heat for long periods of time, or by not being acclimated to exercising in warmer weather. It's quickly relieved by laying the athlete down in a cooler environment, elevating their lower extremities, and then replacing any fluids and electrolytes that they may have lost. Exercise-associated heat cramp, or exercise-associated muscle cramps, are painful muscular cramps that occur during or after exercise. Very commonly, they're going to be found in the calves or in the abdomen, even if those muscles weren't involved in the exercise or the workout. These athletes typically are profusely sweating, and they lose their electrolytes through their sweat. And it can also be brought on through not replacing those electrolytes soon enough while exercising in the heat. More recent research, though, has found that heat cramps aren't just due to electrolyte loss, but due to alterations in neuromuscular control, and that creates muscle overload and fatigue, which causes the cramps to occur. Muscle cramps associated with the heat, these are treated with immediate ingestion of fluids, preferably some sort of sports drink with electrolytes, and then a mild prolonged stretch, or you can use ice massage of the cramping muscle. These next two, exertional heat exhaustion and exertional heat stroke, are very important to understand and know the differences between. Exertional heat exhaustion is the result of inadequate replacement of fluids lost through sweating. So exhaustion is the result of dehydration. Those with exertional heat exhaustion typically are going to collapse, and they're usually profusely sweating. They typically have pale skin, and their body temperature, their core body temperature, is really high. It's found between 101 and 104 degrees Fahrenheit. If the athlete doesn't collapse, they are typically pretty dizzy, or they have pretty poor coordination. They can be found to have stomach cramps or nausea. They usually have a rapid pulse, and they're usually found hyperventilating as well. When it comes to treating exhaustion, heat exhaustion, we're going to treat this immediately by removing that athlete from the heat and putting them in an air-conditioned room. Or if we have one available, we're going to throw them in a cold immersion tub. And we're going to, if we don't have that cold immersion tub, that air-conditioned room is going to be just fine. But we're going to lay them down and elevate their legs. We're then going to immediately begin to rehydrate them with sports drinks, as long as they're not nauseated or vomiting. If they can't take fluids because they're nauseous or they're vomiting, then we have to refer them to a hospital for IV fluids. It's important that we make sure that we continue to cool that patient until their internal core body temp is at least 102, and then we can refer them for further evaluation and treatment. Exertional heat stroke is another life-threatening illness. So heat exhaustion and heat stroke are both life-threatening. But exertional heat stroke appears a little different from heat exhaustion. Although the actual cause of heat stroke is not actually known, it's clinically recognized by someone suddenly collapsing and losing consciousness. That person is also going to have flushed red hot skin, and they're to a point where they're no longer sweating. Rather than, again, that heat exhaustion, we're going to see pale skin, excessive sweating. Heat stroke, they're going to have red flushed skin, and they're not going to be sweating anymore. Those with heat stroke have shallow, rapid breathing and a strong rapid pulse. But most importantly, the most important difference is that with heat stroke, their internal core body temperature is at 105 degrees or higher, which is extremely dangerous and life-threatening. This is basically the breakdown of the thermoregulatory system of the body, and it's caused by excessively high body temps, and the body basically loses its ability to dissipate heat through sweating. So again, it's a life-threatening emergency and must be handled appropriately in order to save a person's life. So in order to save somebody's life who's suffering from exertional heat stroke, the very first thing we need to do is get them in the cold immersion tub. We need to get them somewhere cold, and we need to reduce their body temperature. That body temperature absolutely needs to be reduced to at least 102 degrees within 30 minutes of their collapse. By reducing their body temp to at least 102 degrees within 30 minutes of collapse, we can significantly reduce the possibility of death occurring. Okay? So commit that to memory for sure. If somebody has heat stroke, they need to have their body temperature reduced to at least 102 degrees within 30 minutes of collapse. Furthermore, let's say that we acted really quickly. We got that patient in a cold tub immediately. Somebody called 911 for an EMS. If that EMS arrives before that patient has reached a core body temperature of 102 degrees, we do not let them leave until that temperature is down to 102 degrees Fahrenheit. Okay? Even if the EMS arrives, continue to cool until that temperature is reached. Or we could risk that patient potentially spiking again and returning to that high body temperature. So it's extremely important to understand the differences between all of these heat illnesses, especially between heat exhaustion and heat stroke, and how you can manage a situation where an athlete is presenting with the signs and symptoms of all these illnesses. The last one I want to mention here is exercise-associated hyponatremia. And this is actually something that usually occurs when we're trying to help a patient with a heat illness. If we have an athlete who is low in electrolytes and we tell them, go drink a sports drink, it's important that they do so slowly. We don't want them to guzzle down loads and loads of fluids, because that is what results in hyponatremia. Hyponatremia is essentially where the blood becomes too fluid. There's too much fluid in the blood and not enough electrolytes. Okay, so there's not enough sodium per volume of blood circulating in the body, and that can lead to some pretty severe consequences and also be life-threatening. Those with hyponatremia usually show signs of a headache. They have nausea or vomiting. A lot of times they're going to have swelling in their hands or their feet. They're going to be lethargic, apathetic, or agitated. And the telling sign is that they have low blood sodium. And low blood sodium is going to compromise that central nervous system and cause the athlete to go into shock, which is where that life-threatening aspect comes into play. So if hyponatremia is suspected, The individual should be prompted to rehydrate on a delayed timeline, so they should drink high electrolyte beverages on about a 10 to 15 minute interval, and that fluid intake needs to be controlled, rather than telling a patient, here's a whole bottle of Gatorade, drink it all down and see how you feel after. Okay. If that patient is unable to consume liquids due to nausea or vomiting, again, it's recommended that those individuals are referred for an IV. So we know what the main heat illnesses are, and the good thing is that they're all very preventable as long as we know what we're doing, and we know what to do. The first thing that we need to do is we just make sure that we're not restricting fluid intakes of the athletes. If they're thirsty and it's hot out, let them drink. Let them go get their Gatorade or their water. Don't restrict their fluid intake in a hot environment. Acclimatization is also super important. We need to acclimatize the athletes to warm weather over the course of several days to make sure that they're used to working out in warmer weather. We need to identify susceptible individuals. So if somebody has had a heat illness in the past, they are highly susceptible to having another episode of a heat illness. Ensure that our athletes are wearing lightweight uniforms, and those uniforms preferably are going to be lighter in colors so that they don't absorb sunlight and the heat. Also make sure that we're keeping track of fluids that the athletes are losing at each practice, and that they're replacing those fluids within 12 hours of ending their training sessions. Being familiar with heat index scales is also a great way to know if it's safe for your athletes to practice outdoors. Your program, whoever you're working with, should have recommendations for practices and fluid replacements based on the heat index scale. And if they don't, you should really look at developing that to make sure that the athletes you're working with are practicing in a safe environment. Many sports played in cold weather, especially here in the Midwest. Many sports that are played in cold weather don't require heavy protective clothing, so weather becomes a factor in injury susceptibility. This is especially so if it's windy out or humid out as well. Low temperatures accentuated by wind and dampness can pose major problems for athletes. So especially in the springtime, I used to work with baseball here at Minnesota State, and in the springtime in Minnesota, it's not warm. And it's raining a lot, so it's cold and damp out in the spring, where we mostly think of baseball as a summertime hot weather sport. Those athletes are very affected by the temperatures, the low temperatures, the wind, and the dampness in our neck of the woods. Okay, so what are the different types of hypothermia or cold illnesses? The first one is frostnip. Frostnip is an illness that involves the ears, nose, cheeks, chin, fingers, and toes. And it's commonly going to occur in high wind and or severe cold. Okay, and it's where the skin initially appears very firm with cold, painless areas, and it may peel or blister in a 24 to 72 hour period. If we identify an area affected by frostnip, we need to treat it early by placing firm, sustained pressure on it. But it's important that we're not rubbing the area. We're just applying pressure. The other way we can treat it is by blowing warm air onto the tissue, or by just getting that affected tissue into a warmer environment. Chilblain is another cold illness that we're going to talk about here. It results from prolonged and constant exposure to cold for more than an hour and in temperatures that are 50 degrees or less. With chilblain, the skin over time becomes red and swollen, and the patient is affected by sensations of tingling and pain, especially in the toes and in the fingers. It's caused by problems with peripheral circulation, so it can be avoided by preventing further cold exposure. It's treated by removing any wet or constrictive clothing, and then we're going to cover it with warm, loose, and dry clothing or blankets. So opposite of what we're doing for frostnip. Frostnip, we're applying pressure. Chilblain, we're going to be not applying pressure. We're applying warm, loose, and dry clothing or blankets. If there are any blisters that are associated either with frostnip or chilblain, it's extremely important that we don't do anything with those blisters. Don't touch the blisters at all. Um, don't apply any friction massage. Don't apply any creams or lotions. And then don't put any high levels of heat on those blisters. Just loosely cover them. Cover that tissue with dry and warm material, and monitor that tissue for circulation and sensations to return. Frostbite is the most severe cold illness that we're going to come across. And this causes that skin to appear pale, hard, cold, and waxy. If you palpate that skin, you're going to find that the tissue is hard, nearly frozen on that superficial layer of skin. And it also is starting to freeze, essentially, the lower levels of the skin as well. Superficial frostbite is not as severe as deep frostbite, but superficial frostbite can be managed by slowly rewarming that tissue. That patient that is having that tissue rewarmed is most likely going to feel their skin become tingly as that sensation is returning to the tissue, but then it's going to start becoming a little bit more painful. It may feel hot, it may sting or burn. And then when we get to deep frostbite, that's a serious medical emergency. It's a serious injury and requires medical intervention immediately. Frostbite requires, again, gradual rewarming of the tissue. But essentially what's happening with frostbite is the skin and underlying tissues are freezing, and that frozen tissue is dying. So we need to make sure that that tissue is rewarmed as soon as possible, but gradually. Okay, so during rewarming, the skin will most likely become blotchy and red. It'll become swollen. It'll be extremely painful for the patient. It can even, like I said, result in tissue death. It can become gangrenous after the tissue is rewarmed. So even after we've successfully rewarmed the tissue, we still may lose the tissue itself. So it's important to intervene quickly and get that patient the care they need if you suspect frostbite. When it comes to preventing cold illnesses, much like with heat illnesses, cold injuries, hypothermia type illnesses are also extremely preventable. In the Midwest here, I don't know about you guys, but I was raised to layer up in the cold weather, right? So that's really what the best way to prevent cold injuries is dressing in layers, dressing in as many lightweight, non-restrictive, moisture-wicking layers that an athlete can dress in that aren't going to limit mobility. And that's going to allow the sweat to move away from the body and allow the body to not succumb to the chilling effect that occurs when sweat close to the body gets cold. The athlete should routinely dress in thin layers, and those thin layers should be able to be easily added or removed to prevent sweating as that temperature either decreases or increases. Make sure that we implement a warm-up before exercises to prevent chilling. Part of that acclimatization process, just make sure that the athletes are warmed up and ready to work out in a cold weather environment. And then lastly, just make sure that if an athlete is experiencing any signs or symptoms of a cold illness, let them retreat into a warm environment. Let them warm their tissues back up. Don't make them sit outside when their lips are blue and they're completely numb, right? That's just going to ask for a hypothermic illness to occur, okay? So something that you'll definitely come into contact with and experience throughout your careers is lightning and thunderstorms. We've all seen a thunderstorm, but when it comes to participating in athletic activity, in and around lightning and thunderstorms, we have to take upon several considerations. So lightning is the number 3 cause of death by weather phenomena. So it accounts for 30 deaths per year. So it's extremely important that the institution that you're working for has a thunderstorm and lightning policy in place to ensure that our athletes aren't part of that statistic, that they don't become part of that 30 deaths per year. The most important thing to know is if you hear thunder, lightning's not far behind, okay? If you hear thunder or you see lightning, you are in immediate danger and you should seek protective shelter and move your athletes and yourself indoors immediately. The policy here at Minnesota State, so while I was practicing as an athletic trainer, for Minnesota State, our lightning policy had us monitor lightning strikes within a specific radius. Okay, and we used a lightning detector. If there was lightning within 7 miles in any direction of our athletic activity, we had to stop participation in that activity, and everyone had to seek shelter immediately. We then were not able to resume activity for 30 minutes minimum after the last lightning strike has passed. So there were several times where, again, working with baseball, I would monitor our lightning detector app, and there was a lightning strike within 7 miles. So we had to stop activity, and then that storm continued to get closer, and then eventually it passed. But I wasn't able to give the all clear until the very last lightning strike within that 7 miles of that 7 mile radius had passed. Okay, so 30 minutes had to go by, even if the last lightning strike was at 6.99 miles away. We still had to adhere to that policy until that last lightning strike had been 30 minutes past its strike. Okay, so lightning and thunderstorm policies are extremely important. They're going to save lives, even if they seem a little silly at times. When there may be no lightning or no storm directly above you, if there's lightning in the area, you still are at risk for a strike and you are in danger. So make sure that you are paying attention to your facilities, your programs, lightning policy, and adhering to that policy. Last thing I want to talk about here with some environmental conditions is altitude illness, air pollution, and overexposure to the sun. Altitude illness, so the higher you go in altitude, the less oxygen is going to be available for the body to use. So it makes your red blood cells work a lot harder. There's not as much oxygen being transported throughout the body, so it can result in headaches, nausea, vomiting, sleep disturbances, dyspnea, cough, weakness, mental dysfunction, and even unconsciousness. So moving through higher altitudes, as an athlete, you need to make sure you're also acclimatizing yourself to that altitude, starting out nice and slow, doing less work at the beginning of your acclimatization period, and then starting to increase the amount of activity that you're doing at altitude. Air pollution is another issue that we can see environmentally. The biggest thing that I want to say about air pollution is that it's most common around urban areas. And if you find yourself working in an urban area, to avoid different types of pollution, photochemical haze or smog, some things that you want to do is practice either early in the morning, so at dawn, or make sure you're practicing later in the evenings. Just trying to avoid practicing in those high commuter times, those times where there's lots of traffic on the road, adding to that pollutant in the air. Some of the symptoms that you might see with air pollution or sicknesses associated with air pollution, the athletes may experience shortness of breath, they may cough, they might have some chest tightness, they may have some pain when they're breathing, they may feel nauseous, they could even have eye irritation. They may suffer from fatigue or have lung irritations. And then they also, if they're prolonged exposure to air pollution, they may end up with respiratory irritation that can come about very frequently. They may have lower resistance to lung infections. And then lastly is overexposure to the sun. The sun is great, gives us vitamin D. It's good to be out in the sun, but long-term effects on the skin are really what we're worried about. The most serious effect of long-term effects on the skin is cancer. Okay, so make sure that we are using sunscreen often to prevent that risk of developing cancer of the skin due to overexposure from the sun. Some less severe things that might affect the skin from overexposure to the sun, you can end up with premature aging. You can get wrinkles. You can just look a lot older than you are. I don't know if anybody's ever seen the stereotypical old retired Florida guy that sits out in the sun every single day, but their skin looks like leather, right? Just overexposure to the sun can cause that. It can also cause dryness, cracking, and then decreased elasticity of that skin. So all of that to say that using sunscreen is the best way to prevent overexposure to the sun. Make sure you're taking frequent breaks when you're in the sun. Don't be out there for hours and hours a day, every single day, unless you're using sunscreen. And even then, make sure you're using some sort of sun protective hat or a sun shirt as well to continually protect that skin. Acute injuries are the immediate injuries that usually are brought on by some sort of quick, blunt trauma. These include fractures, and there's many different types of fractures, but also dislocations and subluxations, nerve injuries, ligament sprains, and muscle or tendon strains. That's something else I want to talk about. If it's a ligament that's damaged, ligaments damaged are sprains with a P, and then muscles or tendons that are damaged is strain with a T. Okay, so ligament sprain, muscle or tendon strain. Contusions, which are just bruises. These are all different types of acute trauma or acute injuries. But we can also include things like muscle cramping and muscle guarding. Muscle cramping and guarding are acute injuries that actually are usually the result of some other injury. So they're usually secondary injuries. So if we have an athlete that's cramping or guarding, that's usually going to lead us in directions that are going to bring us to some other form of injury that the athlete has sustained. Or maybe they have a lack of nutrition or they're low in electrolytes that's causing them to cramp or guard. We can even consider muscle soreness as an acute injury. I'm sure all of you have worked out. I'm sure all of you have gotten sore from a workout. And this is because when we work out, we're damaging those muscles to be able to grow and become stronger. So we can also consider muscle soreness as an acute injury. Chronic type injuries, these are the more slow types of injuries, and they often are a result of repetitive stresses. So stress fractures are actually a type of chronic injury, probably the only fracture type that is a chronic type injury rather than an acute type injury. But then with chronic injuries, we also see tendinopathies. And tendinopathy is just an umbrella term, and that term is going to refer to both tendinosis and tendinitis. Tendinosis is the failure of a tendon to heal correctly after it's damaged, and tendinitis is a constant inflammation of a tendon that is still going through the healing process. Bursitis is another type of chronic injury that can happen when those tight tendons, tight muscles, they're moving over these bursa sacs in the body, and those tight muscles or tendons cause consistent pressure and inflammation to occur on that bursa sac. Bursitis can also be an acute type injury. There's a pretty commonly injured bursa sac in the body in the elbow. If a athlete lands with a hard blow to their elbow, they can rupture that bursa sac and cause bursitis in their elbow acutely. But bursitis is usually a chronic type injury. And then lastly, myofascial trigger points. These are what we commonly refer to as knots in the muscle, K-N-O-T, knot. So these are just tightnesses in the muscle that are painful, and they can limit the ability of the athlete to move correctly. So I just wanted to go over these real quick and just briefly go over how important it is to understand these differences because they're both treated in different ways. The healing process. So there's 3 phases in the healing process, but I want to be clear that the healing process it's a continuum. So although we're going to break it down into 3 distinct phases over the next few slides here, I want to be clear that it is a continuum and that there is significant overlap between each of the phases included in the healing process. Just because we see that an athlete is showing signs that they've entered a new phase, that does not mean that they are completely done with the previous phase. So beginning with the inflammatory phase, this is where inflammation occurs due to some injury. And now inflammation itself, the word inflammation, has a lot of negative connotation to it. but it's actually an essential part of the healing process. Without the inflammatory phase, we cannot enter the healing process and return an athlete or a patient to full function and return to play. We can't progress into the repair or remodeling phase, and the athlete is going to be stuck at whatever level of function that they're currently in if we don't go into that inflammatory phase. So this is one of the most, if not the most critical phase of the healing process, because it starts everything off when it comes to healing an injury. This phase is going to be marked by pain, usually significant pain. Sometimes there can be warmth over the injury site. It's warm to the touch. We typically are going to see some swelling, loss of function and range of motion, and then they can possibly see discoloration, so red or blue discoloration at the site of injury. This phase is going to begin immediately after an injury occurs, and it's going to last anywhere from 24 to 72 hours typically, but it can last up to 4 days after an injury has been sustained. The fibroblastic repair phase comes after the inflammatory phase, and is probably it's another critical phase of the healing process. Mainly, it's important to know this because if we recognize that an athlete is in the fibroblastic repair phase, if we move them through this phase too quickly, there's not going to be enough repair that's done to the tissue, and it's going to remodel incorrectly. But if we move through too slowly, that athlete is going to be in a lot more pain than they're going to need to be in. They're going to have loss of function for a lot longer than they should. They're not going to be able to return to play as quickly if we move them too slowly through this phase. In the inflammatory response phase, proliferative and regenerative activity leads to scar formation or fibroplasia and repair of that damaged tissue. So scar tissue formation or fibroplasia, it's going to begin within that first few hours after an injury has occurred. And it's going to last anywhere between 4 and 8 weeks, depending on the severity of the injury and the type of tissue that was damaged. So anywhere from 1 hour after injury to 2 to 4 hours after injury, all the way up to 8 weeks after that injury has occurred is when we're going to be in this fibroblastic repair phase. A lot of times this phase is, especially when we get towards that 4 to 8 weeks post-injury, a lot of times this is where those athletes are going to start feeling better. They're going to be able to move a lot easier. They have a lot less pain. But it's important that we still recognize that an athlete is in this stage, or if they're not, right? We need to recognize it. Because if, again, we progress them too quickly because they are feeling better, that's going to prolong their total time that they're spending in this phase of the healing process and ultimately result in a slower return to play. Lastly, we have the maturation remodeling phase. This is going to be our final stage of the healing process. And this is where we're going to have that scar tissue that was laid down in the previous phase. That scar tissue is going to start remodeling itself and realigning itself. Okay, and that's going to be directly affected by the amount of strain or stress that we place on that damaged tissue. If we have somebody who has a muscle strain and we immobilize that tissue, there's no stress or strain that's placed on that tissue, so those scar fibers are going to lay down all haphazardly, and there's going to be no stress to line them back up in their correct orientation. So this phase is important to understand because when we are in this phase, we want to make sure that we are exercising and we are moving the muscles that are damaged to be able to realign those fibers and remodel those fibers correctly. The other reason that it's important to recognize this phase is because scar tissue, even though it is strong, it is rarely, if ever, as strong as the normal undamaged tissue. So again, the athletes are usually feeling really good when they reach this phase of the healing process, but that scar tissue still is remodeling and realigning itself, and it's still vulnerable to re-injury. So we need to make sure that we are taking our time and making sure that the athlete is fully functional before returning to play. This is usually going to begin around that 3 to 4 weeks after injury. So after that scar tissue has started to lay down, and then it's going to last, depending on the injury, up to several years. With a muscle strain, we can typically see full maturation and remodeling occur after several months, usually around 8 to 10 months. But if it's a ligament, we're going to be looking at that remodeling phase, maturation phase, move into the several year mark. So ACLs are a commonly damaged ligament, and even though we see oftentimes athletes return from an ACL reconstruction after about a year post-surgery, that ligament is still remodeling and healing up to 3-4 years after they've received that surgery. So even though they're still strong, they're functional, when they're in this maturation remodeling phase, they're still vulnerable to re-injury for the rest of their life, because that scar tissue isn't going to be as strong as that normal tissue, and because it takes so long to actually go through this entire phase. So the signs and symptoms associated with the maturation remodeling phase, we're going to see again that return to normal function. The patients are going to be feeling a lot better. They're going to be moving normal. They're going to have little amounts of pain, if any at all, and then they're going to have full range of motion. So it's going to be our job to recognize if they're actually going to be able to perform and work with their teammates and in their sport safely. Any time that an athlete goes down, we have to start going through a series of steps to ensure that proper care is given to the athlete. So after an injury happens, we begin our primary survey. So the primary survey is simply making the recognition on if our patient is conscious or not. Okay, that's our first step. This is also why it's important to be attentive at our practices and not on our phones or doing other things or goofing around, right? We want to be attentive to be able to see what's going on. If an athlete goes down and they're unconscious, it's important that we know what caused them to go unconscious. It's also important to know why they're still conscious or why they went down, right? Was it a non-contact injury and is it hot outside? That's going to point us in the direction of a heat stroke. If it's not hot, maybe they have some other illness. Maybe they have asthma and they had an asthma attack and that caused them to go unconscious. So making sure we're paying attention is extremely important, right? Even if it's a contact injury too, right? Did they get hit in the head, in the neck? I once saw a wide receiver in football. He laid out for a catch and one opponent hit him on the right shoulder and the other opponent hit him on the left leg, and he spun around like a helicopter and landed on the ground unconscious. So that was another thing that I was able to see, and I knew what happened, so I was able to have a better idea when I got to the patient on if I needed to take any additional steps for caring for that athlete. Starting with the left side of this flow chart, the unconscious patient. So our first step with an unconscious patient, whether we've seen them get hit in the head or neck or not, our first step is to stabilize that C-spine. We just want to make sure we're preventing any further injury that may result in paralysis of that individual. So whether they've gotten hit in the head or not, if they're unconscious, make sure we're in a stabilized C-spine first. Then we need to check our ABCs, our airway, breathing, circulation, all okay in that patient. Is the airway clear? Are they breathing normally and under their own power? Do they have a pulse, and is that pulse normal? And then after we've checked those ABCs, we need to note any profuse bleeding. If they've gone unconscious and they're bleeding, we may need to suspect that they're going into shock due to severe blood loss, and we need to control that bleeding. At any rate, after we've checked all that stuff, we need to have someone call 911. If we have the ability to have somebody by us, we have them call 911 and we continue to care for that patient. So that person will call 911 and activate EMS first. And then they will also be directed to gather an AED for us to use to start CPR if that's necessary. If we're by ourselves, we need to make sure that we are to the patient. We take our phones out and put it on speaker, call 911, and then we start doing CPR while we are on the phone with 911. If, again, we are by ourselves and we realize that the patient needs CPR, if there's an AED really close by, we are going to go get that AED first while we're calling 911, and then come back and then begin attaching that AED to that patient first. Okay. In the event that our athlete remains conscious, we begin mostly with the same thing. So checking that airway, breathing, and circulation. Really, can they talk to us? If they can talk to us, typically that's going to identify the patient as having a clear airway, they're able to breathe under their own control, and they have good enough circulation that's going to continue to allow them to be awake and alert. But then we enter our secondary survey. So the secondary survey is where we take a closer look at the injury that the athlete sustained. This assesses the vital signs of the patient, so our heart rate, blood pressure, etc., and gives us a more detailed evaluation on what we need to do next. We gather information about what we saw and ask that patient what they experienced. Do they recall everything that happened? Did they feel any sort of sensations, popping, snapping, cracking, anything like that? Do we visibly see any abnormalities? So any deformation in any bones, any bleeding, etc. And then if we're able to, we'll give the athlete plenty of time to prepare, make sure they're calm, take care of anything immediate, and then we're going to try to get them to the sidelines. The one thing I want to say about this is that when you are the one taking care of the athlete, you are the one that is going to make the decision on when they come off the field. Okay? Don't let any other coach, don't let any referee, any other player talk you into moving a patient before you tell or you deem that patient as being ready to move. Okay? I've had a lot of situations where an athlete's gone down in the middle of a field, and I've had a coach come over to me and say, "Can we get him to the sideline?" And I'm in the middle of my evaluation, and I have to take time out of my evaluation to turn to that coach and say, he will be moved or she will be moved when I say they're ready to be moved. Okay? Don't let anybody peer pressure you into moving an athlete before you are completely sure that they are able to be moved. Okay? After we've given them time to prepare and we've moved them to the sidelines, put any braces or splints or anything that we need to on the field, and then we get them to the sidelines, then we're going to continue to assess and find if we need to refer them, if they're going to be out for the rest of the game, or if they are going to be able to return to play after some time to rest and recover. So this flow chart seems very simple, but it's extremely useful. I've relied on this flow chart for my entire career, and I've had situations on both sides of this chart, both conscious and unconscious patients, that I've had to follow this chart and use this chart. One time I had an athlete who was wrestling, and they were put in a vulnerable position by an opponent. They went down, and after I made my way out onto the mat, again, I started with my ABCs. Were they able to talk to me? And basically what I did was I asked them if what they experienced was the same as what I saw. I saw them being put into a position with their arm that no human shoulder should ever physically go into. And I thought I saw it come out of socket. And that actually matched with what the athlete was saying. They felt a pop, their arm was out of socket. So I was able to calm them down on the mat and reduce their shoulder. And then we were able to get them off of the mat after I reduced their shoulder, and then I referred them to their athletic trainer and team physician. A more serious case that I had on the unconscious side was actually not even with an athlete. It was during an athletic event, but it wasn't an athlete that went down. So I was actually working with a football team, and there was a young boy who was acting as the ball boy for our team. Went through warm-ups, everything was great. Me and this kid were just goofing around, throwing a football back and forth, just waiting for the game to start. And then opening kickoff happens, and our team returns the kick for a touchdown. Everybody's celebrating, high-fiving, everybody's super excited, and then our ball boy goes to the end zone to retrieve the football. On his way back, me and him were still cheering, yelling at each other, being happy, and then all of a sudden he just fell on his face. I thought he tripped in a pothole or something, and that he was just too embarrassed to stand up right away, but he was just pancaked on his face. Okay, Made my way over to him and found that he had gone unconscious. And it turns out that he had an undiagnosed heart problem, and that he was having essentially he was having a heart attack at the age of 10 or 11. Okay, so I went to him, turned him on his back, and tried to assess his level of consciousness. He didn't respond to any of my verbal cues. He also didn't respond to any pain cues. So I did a sternal rub on his chest, and he still didn't respond. So I checked his pulse. It was extremely faint but very rapid. Um, Thankfully, I had people around me, so I had somebody call 911 to activate EMS, and I had somebody else go and grab the AED from my med bag while I began chest compressions. We were able to get him hooked up to that AED very quickly, and a shock was advised, so we had to shock him. And then thankfully, the EMS was there very quickly, and he was able to be transported to the hospital that was 10 minutes away. And also, thankfully, he survived, and he actually just graduated from high school a few years ago. So he's doing well. If anybody's wondering, we were able to save him. He's doing great. But I tell you that story because it just goes to show that when we're looking to prevent or care for injuries, we always need to be ready. Injuries can happen at any time, and we need to be ready to act when they do. Okay. I also tell you that story because, again, it happened on that very first play of the game. I had to go through all of that craziness dealing with that patient, and then I had to, after he was transported with by the ambulance, I had to go back to the game, and I had to care for the rest of the athletes that were out on the field. So we need to make sure that we're ready for injuries whenever they happen, and make sure that we can compartmentalize ourselves. When an injury does occur, it doesn't mean that another one isn't going to occur, right? Something as crazy as somebody going unconscious and needing to be transported to hospital doesn't mean that somebody else isn't going to go down with a minor ankle injury that we still need to care for, right? So even when an injury occurs, it doesn't mean that things are going to go quiet and we already dealt with one injury so we can check out for the rest of the game. Injuries can always happen, and honestly, in my experience, they often happen back to back to back. So just always be ready and be very aware of this flow chart and how you are going to use it to care for your patients. So when it comes to immediate treatment for musculoskeletal injuries, which is mainly what we'll be seeing with athletic competitions or athletic events and athletic injuries, when it comes to immediate treatment of these injuries, we're going to use the acronyms ICE, RICE, or PRICE. Okay, so I'll just break down PRICE because it has everything in it. So P is for protection. That is really what comes down to is optimal loading. So let's say it's a lower leg injury. Can the patient bear weight? Do we want them to bear weight on that injury, right? So we want to make sure we're protecting that patient, even if they are able to bear weight on that leg, that lower body injury. Do we want them to? Is bearing weight on that leg going to increase the amount of damage to the injury itself? Okay, so that's going to be protecting that patient. Resting, so kind of out of order with that acronym. If the patient can return to play, they need to rest as much as possible when they are done. If they can't, then we need to follow the other letters of the acronym and have them rest in conjunction with those other letters of the acronym. Compression is important because we need to wrap the injury if possible and limit the amount of swelling that occurs. Through limiting that swelling and inflammation, we're able to keep levels of range of motion fairly normal. We're also able to reduce the amount of pain that the athlete is going to be experiencing. If we limit the amount of swelling in an area, it's not going to allow that increase in fluid to press on the pain receptors in that area, and it's going to help limit the amount of pain that they're experiencing. And elevation is also going to help limit the amount of swelling in the area, so that's also going to add to the amount of pain that the patient is going to be experiencing. So I don't know if you noticed, but I also just kind of skipped over ICE, the I in PRICE. And I did this because icing an injury or applying cold modalities to an injury is kind of a hot button issue in the field of sports medicine. Some suggest that ice is actually going to slow down the injury healing process and that it results in a prolonged return to play timeline. While others are suggesting that ice is going to be the best thing, and it's not only going to help with pain, but it's also going to lead to faster healing times because the amount of inflammation and secondary injury is minimized. I personally don't use ice right away because with the research that I've done, I find that athletes respond to compression and elevation much better, and they're able to recover much quicker than if ice is also used. So that's just my opinion. Do your own research, find out what works best for you and with your patient population, but that's just my personal opinion when it comes to icing. Splinting is important to understand. You may find yourself in a situation where you have a fracture in a patient and you have to splint that injury. So emergency splinting, after you've taken care of any bleeding or anything like that, you suspect a fracture and you need to splint. So uh, when it comes to a suspected fracture, make sure that you splint any and all suspected fractures before you move the patient at all. Um, and make sure when you're splinting that you are splinting both above and below that fracture site. Um, when we splint just the fracture, if the muscles move, they can still move that fracture site and cause a great amount of pain. So we want to make sure we're splinting both above and below that fracture site. Some different types of splints that are commonly used in sports medicine. The first, and in my opinion the best, are the vacuum splints. So these are just some sleeves that we put around a body part, a limb, and then we take this little vacuum and remove all the air from that sleeve, and it's just going to form fit to that limb, and it's going to immobilize that fracture site. Air splints are the exact opposite. So these are, you can see this is the middle picture around that ankle. That's an air cast splint. That is a little pocket that is filled with air to immobilize an area where we suspect a fracture. That air splint there, that air cast splint, actually has some hard sides on it to provide a little bit further protection, but its main job is just immobilizing that ankle. And then lastly, we have SAM splints, which are probably the ones that I use the most. They're not the best, but they are the ones I use the most because they're so versatile. You can make the SAM splint, you can adjust the SAM splint to any body part, any limb, and you can adjust it around the contours of various patients' limbs. They're very versatile, very good to use. I use them quite a lot throughout my practice. So those are just some of the different types of splints and just the basic instructions for using splints. Splinting is actually kind of a nuanced practice when it comes to taking care of our athletes. So when it comes to splinting upper body injuries, whether that's a shoulder dislocation, a humerus fracture, forearm fracture, whatever you're dealing with, you want to make sure you're splinting that limb in the position that it's found. Okay, so don't try to reduce any fracture. Don't try to make the bone go back straight because that can actually cause more damage. So make sure that we're splinting that limb in the position that it's found. When we do get that splint on there and we immobilize that fracture site, then we're going to support that arm with a sling. When it comes to hand or finger dislocations or fractures, then we can use things like tongue depressors. If we don't have an actual aluminum splint that's made for finger dislocations or fractures, then we can use a tongue depressor and some tape to immobilize that finger, and then wrap it with gauze to protect it further. Splinting lower body injuries, again, we are splinting those injuries in the limb position that we found it in, and we're ensuring that we are immobilizing that fracture site by also immobilizing the joints above and below that fracture site. So if we have a tibia fracture, for example, we want to make sure that we're including the ankle and the knee in that immobilized area. Okay, we want to make sure that we immobilize everything above and below that fracture site because any motion of those muscles throughout that ankle or throughout that knee can have an effect on that fracture site at the tibia. Okay, so making sure that we are doing that for the upper body as well, making sure that we are immobilizing above and below the fracture site. Hip and pelvis fractures and dislocations are a little bit more difficult. These are pretty hard to splint in isolation. So really what we're doing is we are just making sure we are limiting the amount of movement that the patient is going through, and then we are going to spine board them and transport them to the hospital to receive further evaluation. Moving and transporting athletes. So I just want to really break down C-spine injuries here. If we suspect any cervical spine injury, the first thing we're going to do is immobilize that C-spine, okay? And then after we've immobilized, we are going to add that C-spine collar. And then if recommended by our emergency action plan, then that is when we will remove any equipment. So a helmet, face mask, things like that, shoulder pads. If it's recommended and has been practiced, then we will be removing protective equipment before spine boarding that athlete. And then spine boarding the athlete takes a lot of skill, coordination, practice. So this is something that definitely needs to be gone over with the other members of your sports medicine team. Make sure that you know what your role is going to be. You've practiced multiple different roles when it comes to spine boarding an athlete, and that you know what you're going to do if the situation arises. Moving the athlete, so we've performed one of the many ways of getting the athlete onto a spine board, and then we are going to do a stretcher carry. So it's a coordinated team lift, trying to keep that patient as level as possible, making sure that everybody's got a good grip so we don't drop the patient, and then we stretcher carry that patient to some sort of cart or ambulance. An ambulatory carry or an ambulatory aid is just what we see at the bottom three pictures in the middle, just getting the athlete to put their arms around us, and we are just going to support their weight. A lot of times I've had athletes where if I'm by myself, they are able to usually put weight down on one limb, and I tell them to use me when they're trying to put weight down through their injured limb. Don't put any weight down through that injured limb. Use me as their leg, essentially. If we have a partner, then we can take even more weight off of that injured limb, even stand up straight and carry that patient so they don't have to put any weight down on either leg. And then manual conveyance is just like a partner carry. So this is the bottom right picture. Just a seated carry, having the patient sit down on our arms and holding on to us as we ambulate them off of the field. Whether you've used crutches or not, or if you've fit somebody for crutches or not, I just want to go over it again to make sure that everybody's on the same page. So when we're fitting crutches, we've established that an athlete needs crutches. We found an appropriate size. We've asked the athlete how tall they are, and we found the appropriate height of crutches for them. Most crutches have a little button on it that has the height recommendation for each adjusted height. So we usually set it to that right away, and then we are going to have that athlete stand up as straight as possible. When we have that athlete stand up, then we're going to have them hold the crutches, and the bottom part of the crutch, the part that touches the ground, that part is going to be placed about 6 inches either left or right from the foot, and then about 2 inches in front of the foot. That's going to be the first position that we put those crutches in. In this position, this is where we are going to determine if that crutch is the appropriate height or not. After we've reached that 6 inches laterally and 2 inches anterior to the person's foot, that underarm padding should be about 1 inch below that armpit. So I usually take 2 fingers, 3 fingers, and I put them in the armpit of that athlete and see if that padding is touching one side of my fingers and the other side is touching the underarm of the patient. If there's contact with my fingers in their armpit and the padding, then it's pretty good placement for that crutch. When it comes to positioning the hand grip of the crutch for the patient, we want to make sure that hand hold is set to a position where that elbow of the patient is at about 30 degrees of flexion. So they're going to be in a nice relaxed position. So we fit the crutches, and now we need to teach our athletes how to walk with the crutches. You'll be surprised at how many people have never used crutches and how difficult it is to actually use them when they've never used them before. So the first thing I always say to my patients is we're going to be moving to, not through. And by that I mean when they move those crutches forward, they are going to be moving their body to the crutches. They're not going to be swinging their body beyond those crutches. They're not going to swing through the crutches because when they do that, especially if it's winter here in Minnesota, those crutches can slip behind them and then they can fall and cause themselves further injury, which nobody wants. So make sure that we're going to, not through. Yeah, it's a little bit slower, but it's a lot safer. So to, not through when walking with crutches. Next, I'd like to talk about using crutches and moving up or down stairs. This is another thing that I find that is pretty hard for a lot of people to comprehend, honestly. But with the one rule that I have here, it makes it a little bit easier. So that rule or that recommendation is up with the good and down with the bad. So if we are going upstairs, we are going to take both of the crutches and we're going to put them on one side of the body. And then that patient is going to move up the stairs by moving their uninjured limb up and then bringing their injured limb up second. Okay, so they're going to go up with the good while also making sure that they're using the handrail, right? We want to make sure they use the handrails for their own protection. When they're going down the stairs, they are going to do the same thing. Move those crutches to one side, grab the handrail, but they are going to be moving their injured limb down first and then following it with their good limb. Okay, and then they go step by step all the way down until they've reached the bottom of the steps. The best thing for any athlete that is using crutches is to have them use an elevator. But if we're in a facility that doesn't have an elevator, they have to use steps, then the up with the good, down with the bad recommendation is the best way to go.